Nathan, in a minute, I'm going to ask you about the long-term follow-up and kind of the real world for older patients, but I want to ask Matt quickly about, there are a couple of abstracts that were presented at ASCO that I think are fairly preliminary, but I think intriguing at least. One being the idea of retreating patients, and the other as far as moving towards second line and how you see all of that emerging.
Yeah, if there's a second product that's made and a patient relapses and they had a CR and they are relapsing at 12 months, I would look at them if they're an allo candidate, right? And that you could go to allo and they didn't have high grade toxicity. I'd be having the discussion, and that's, I think, what the data showed, is that those people who had an early a response and didn't have much for toxicity, you could probably, CAR T cells still, compared to chemotherapy in a double or a triple refractory patient, has a good odds to get you, into remission. I would be trying to consolidate and using the CAR T cell now as a bridge to a different form of cellular therapy that we have been using for much longer than CAR T cell therapy. Which would be an allo transplant if they're able to. Doing it in a person who I can't bridge to something, I think I'd be looking for a CAR T cell plus a novel combination, or not doing it at all if it was too cost prohibitive.
Cami, what do you think about second line therapy? Where do you think there were data presented at ASCO suggesting that the PR patients still can do well with an auto transplant? We have randomized trials looking at second line CAR T versus chemotherapy and transplant. What are your thoughts on that at this point? Is there a patient in practice, assuming you have access, where you've made choices in that, or do you pretty much give everybody the second line chemo at this point?
So at this point, if somebody is there was a trial with one of the products, and now there's a second trial looking at those early progressors or those patients who are refractory, and if I can get them on the trial for a potential for the CAR T therapy as opposed to just giving them chemo, I think that's great. Otherwise, at this point, we'll give them just chemo. I do think that in these patients that probably we are going to see a benefit to giving the refractory ones CAR T over just giving them a platinum salvage and auto transplant. As far as a patient's response to chemo, I think some of that depends on how you define the PR. I mean, if somebody has a ton of disease and they get a partial response, but they still have a ton of disease, versus if they haven't achieved a CR, but they have very minimal disease activity, that there is probably more benefit to proceeding to transplant in that second population. I think the one area of interest is the patients who are not candidates for auto transplant, but maybe they're candidates for CAR T. There's no real definition of who fits a candidacy for CAR T, but typically has to be somebody with at least reasonable performance status, good cardiac function, lung function. And so in that group of patients, there was an ASCO abstract that showed being able to infuse CAR T in those patients who were considered candidates for transplant. And I think that is a great group to target for this therapy also.
So Nathan, MD Anderson has been involved, as has Ohio State and Nebraska, with some of the earlier trials. What's your experience with the long-term follow-up of patients treated with CAR T? There was some data presented at ASCO. Your sense of, I tend to tell people it's a third. A third of people have a long remission, a third have a short remission and transient benefit, and a third get really zero. Is that what you tell people, or how do you look at it?
Yeah, I think we've seen now long-term follow-up along with real life experience, I guess, with it's at least two of the big CAR T cell products, and you hit the nail on the head. I think it's somewhere I like Matt's analogy of apples to apples to apples. If you look at although the response rates and the CR rates are a little different, if you look at the long-term durable remissions across all three of these products, it's in the mid-30s, I think, maybe in the low 40s with most of these patients. And I think that tends to be confirmed with, again, not only long-term follow-up, but the real life experience with a lot of these trials. And we also, I mentioned about that we we've also seen the outcome of elderly patients. There was an abstract at this recent ASCO suggesting that elderly patients also do fairly well with CAR T cells, slightly less well, but still you're looking at 20-30% of patients that are probably going to be cured in the elderly population with